Here's the truth. Nobody tells you early enough. Most students who fail their NEET-PG or FMGE exams are not failing because of a knowledge gap. They're failing because they're playing the wrong game entirely. They're treating MCQs like theory questions. Read the textbook, write the answer. That's the I read, I wrote approach, and it will kill your rank. MCQs test something completely different. They test pattern recognition, not just recall. They test precision, not volume. They test your ability to make decisions under uncertainty and time pressure. You are not rewarded for knowing everything. You are rewarded for choosing the single best answer, fast, clean, and without second-guessing yourself. Understanding this shift is the single most important thing you can do before you solve even one practice question. So here's what I want you to do before we go further. Get one coffee, one blank page and a pen. No phone, no tabs, just you and this. Because what we're about to go through will change the way you think about every MCQ you ever solve from this point forward. Every MCQ, every single one, has 4 layers. And once you see them, you can never unsee them. Layer 1 is the surface story. That's the clinical vignette, the long paragraph they give you to set the scene. Layer 2 is the hidden concept, usually just one idea being tested. Just one. Layer 3 is the trap construction, the distractors. These are not random wrong answers. They are specifically engineered based on the most common student errors. And Layer 4 is the expected response, what separates the average student from the top performer. Here's the mindset shift. Examiners are not asking, what do you know? They are asking, where will you slip? Let's work through this. Look at this question. Your first reaction is probably, wow, that's a lot of information. And that is exactly what the examiner wants you to feel. Overwhelmed. So let's strip it apart, layer by layer. Layer 1, the surface story. This is the long, clinical vignette designed to look complex and intimidating. What do we see on the surface? An elderly patient, 62 years old, long-standing diabetes, shortness of breath, and leg swelling, classic heart failure symptoms, LVH on ECG, and preserved ejection fraction on echo. The examiner's goal here is to overload you with information so you stop thinking conceptually and start pattern matching blindly. Don't let that happen. Layer 2. What is actually being tested? Just one thing, diastolic dysfunction leading to heart failure with preserved ejection fraction. That's it. HFpEF. What matters here? Concentric LVH, impaired relaxation, and a normal ejection fraction of 65%. Everything else, the age, the diabetes, the hypertension, is supportive information. It's not the core. The examiner is asking one clinical question. Can you differentiate systolic heart failure from diastolic heart failure? Layer 3, the traps. And this is where most students fall. Let's go through each wrong option. Option A, dilated cardiomyopathy. The trap here is that the patient has heart failure symptoms, and some students immediately think dilated CM. But wait, dilated cardiomyopathy means reduced ejection fraction. Here, EF is 65%. That trap catches everyone who equates heart failure with low EF. Option B, restrictive cardiomyopathy. This one is clever because it does involve diastolic dysfunction. But restrictive CM usually has normal ventricular wall thickness, and it's caused by things like amyloidosis or sarcoidosis, not diabetes and hypertension. The LVH here points away from restriction. This one catches the student who memorized, quote, diastolic dysfunction equals restrictive cardiomyopathy without thinking it through. Option C, hypertrophic obstructive cardiomyopathy. Because the question says LV hypertrophy, right? But HOCM shows asymmetric septal hypertrophy. It's typically younger patients. There's LVOT obstruction, a systolic murmur, none of which is mentioned here. This option catches students who see LVH and panic. Layer 4, the expected response. Here's what separates the average student from the topper. The average student thinks heart failure. LVH may be restrictive cardiomyopathy. They fall for partial matches. The top student thinks elderly patient, diabetes, hypertension, concentric LVH, impaired relaxation, normal EF. This is HFpEF. They identify what is essential, what is distractor, and what single diagnosis unifies every single finding in the question. And yes, some MCQs in the exam are easy, like what is the most common cause of cell injury? Hypoxia, simple. Even the candidate with minus 40 marks gets that one. It's the hard, long, complex question that separates toppers from the rest. That's the game we're training for. Now let me give you the framework I want you to use for every single MCQ going forward. 6 layers. In order. Never reverse this order. 1. What is being asked? 2. What is the core concept? 3. What keywords confirm the concept? 4. Which options are impossible? 5. Which option fits best, not just fits? 6. Is there any examiner trap I recognize? Print this. Tape it to your wall. Tattoo it somewhere, if you have to. Because the order matters. Students who reverse this, who look at options first, get trapped every single time. Golden rule, and this one alone can push your score by 10 to 15 marks. Read the last line first. Why? Because the last line tells you exactly what is being asked. Is it about diagnosis, mechanism, investigation, management, an exception? When you read the last line first, you prevent cognitive overload from those long, dramatic stems. After reading the last line, you scan the rest of the vignette only to confirm, not to interpret. And you actively ignore decorative history, excessive lab values that weren't asked about, and dramatic storytelling. MCQs are not novels. They just sometimes pretend to be. Here's something that will simplify everything. Almost every single medical MCQ tests one of just 5 things: pathogenesis, association, investigation or drug of choice, management of choice, or exception and contradiction. Ask yourself, if I had to reduce this question to one line, what would it be? If you cannot do that, you are not ready to solve it. That single line reduction is your North Star. Let me show you with 3 examples. 1 line reduction. What causes hypertension in Phaeochromocytoma? Core concept being tested. Pathogenesis. The examiner's trick. The symptoms push you very quickly to the diagnosis. Pheo is obvious. The real test is whether you know why the blood pressure rises. Not which hormone. Which mechanism? The average student thinks hypertension means renin or aldosterone. They pick A or D. The topper thinks Phaeochromocytoma releases catecholamines. Catecholamines cause alpha-1 vasoconstriction. Option B. Done. 1 line reduction. What is the confirmatory test for celiac disease? Core concept. Investigation of choice. Here's the trick. The examiner already gave you a positive screening test, the anti-TTG IgA. What's the next decisive step? The average student confuses screening with confirmation. They pick D or A. The topper knows this cold. Serology screens, histology confirms. Duodenal biopsy. Option B. And that's the truth. I'm not just saying it because I'm a histopathologist. 1 line reduction. What causes acidosis in DKA? But wait, read the last line. The word except is there. This is an exclusion question, not a pick the right answer question. The trap. When students see metabolic acidosis, they reflexively think lactic acid. So they pick D as a cause of DKA acidosis. But DKA acidosis is ketone-driven, not hypoxic. Lactic acidosis is not the defining mechanism. DKA equals insulin deficiency, which leads to lipolysis, which drives ketogenesis. Lactic acid accumulation is not part of that pathway. Option D is the exception, the correct answer. And this is why the golden rule matters. Read the last line first. That single word except changes everything. Let's talk about keywords, the signals, the triggers, and the traps. High-yield signals, age extremes, duration, acute versus chronic, a single dominant symptom, and negative findings, because absence is often the key. Now the trap words. These will make or break you. Most common. Best next step. Gold standard. Accept. First investigation. The word accept alone converts a simple recall question into a ranking trap. Don't underestimate these words. They have broken thousands of dreams in NEET-PG, INICET, USMLE, and FMGE. Do not walk past them. Stop. Reread. Then solve. Here's a huge mindset shift. Average students look for the correct answer. Top students eliminate the wrong answers first. Step 1. Eliminate physiologically impossible options. Step 2. Eliminate options from irrelevant organ systems. Step 3. Eliminate options that are partially correct, but incomplete. Step 4. Choose the most specific remaining option. Specificity beats familiarity. Always. And here's my personal tip. Read Sherlock Holmes novels. I'm serious. Not because it's fun, though it is, but because they teach you the science of deduction. The process of elimination as a systematic discipline. Thank me later. There are two types of MCQs, and most students make the fatal mistake of treating them the same. Pattern-based MCQs are the classic triads, the image-based questions, the one-liner clinchers. These should be answered in 2 to 5 seconds. You see it, you know it, you move on. Concept-based MCQs are the modified presentations, the mechanism questions, the why questions. These require slow, deliberate thinking. You do not rush these. The mistake most students make is applying pattern speed to concept questions and conceptual overthinking to pattern questions. Learn which type you're facing and switch gears accordingly. This is where ranks are actually decided, when you have 2 close options and can't choose. Ask yourself 3 silent questions. 1. Which option is more proximal in pathogenesis? 2. Which option explains all the features, not just one? 3. Which option would the examiner expect a topper to choose? Avoid 2 things: emotional attachment to familiar terms and overinterpreting minor details. Akkad bakad bombebo. I had to say it. Here's the truth. The correct option usually feels quietly obvious. Not dramatic, not surprising. Quietly, calmly obvious. If you're being dramatically pulled toward an option, that's the trap talking. If you are adding facts that are not given in the question, you are overthinking. If you are creating hypothetical clinical scenarios, you are overthinking. If you are wondering whether the examiner made a mistake, you are definitely overthinking. MCQs reward textbook logic, not clinical creativity, not differential diagnosis generation, not your personal experience from the wards. If the question looks straightforward, it usually is. Simplicity is key. Don't make it complex. The elegant answer is usually the correct one. Never randomly guess. But educated guessing? That's a science. Here's the hierarchy. Common over rare. Central mechanism over peripheral description. Pathogenesis over symptom description. Objective tests over subjective findings. What to avoid. Options with absolute words like always or never. Vague, overly broad options. And this matters. If the negative marking is minus 0.25, educated guessing is a very good option. Do the math. You need to be right once in 4 attempts to break even. If negative marking is -1, skip it. The numbers just don't work in your favor. Educated guessing can fetch you 20 to 30 extra marks. Do not leave that on the table. Different subjects need different lenses. For pathology, morphology first, IHC later. Pattern over marker. Usually one histologic feature clinches the diagnosis. For medicine, think in syndromes. Timeline matters. Chronic versus acute changes the answer. Management MCQs are guideline biased, so know your current guidelines. For pharmacology, mechanism first, side effects second. Know your prototype drugs, not brand names. For PSM, definition precision is everything. Know your statistics concepts over calculations. And one more thing. Remember that many of the examiners who set these papers come from a millennial academic framework. They want criteria-based answers. They want definitional precision. Sometimes they want the official answer, not the mechanistic one. Adapt accordingly. Image-based MCQs need a completely different mindset. And the rule is simple. Describe before you diagnose. Step 1. Identify what you're looking at. Tissue, organ, instrument, drug label. Step 2. Identify the dominant pattern. Step 3. Identify the specific distinguishing feature. Step 4. Only then choose your diagnosis. Jumping directly to diagnosis from an image is the most reliable way to land in a trap. And here's a heads up for INICET specifically. They are now putting live pictures from OPDs, labs, and microscopes. Real patient photographs. Real stained slides, which means your ward rounds and lab practicals are no longer optional. Attend them. These points are being tested. I'm not going to sugarcoat this. PSM and statistics MCQs. Boring topic. No magic shortcut from my side. You have to ratify it. You have to grind through it. I'm sorry, but the marks are there, and the other students are grinding too. So this is one area where hard, repetitive work beats strategy. Put in the time. Inside the exam, time management is as important as knowledge. Divide every MCQ into one of 3 buckets. Immediate. Answer in under 10 seconds. Move on. Thinking. Spend 30 to 60 seconds, maximum. And skip and return. Some questions will try to hijack your brain. Don't let them. Never let one MCQ steal time from 5 others. If you're spending more than 90 seconds on a single question, mark it, move on, and come back. The questions waiting for you are probably worth more points than the one you're stuck on. The exam is not where ranks are decided. The analysis after the exam is, after every practice session, ask yourself why you were wrong, and categorize it. Was it a knowledge gap? You simply didn't know it? Was it concept confusion? You knew the information but applied it wrong? Was it overthinking? You knew but talked yourself out of the right answer? Or was it a speed issue? You ran out of time? Each category has a different fix. Write one-line takeaways, not long notes. And give more grand tests, GTs. Every platform has them. The student who does the most GTs and analyzes them the most carefully is the one who moves up the rank list. Every single time. Let's bust some myths before we close. Myth 1. More MCQs equals better rank. False. Quality of analysis beats quantity of practice. Myth 2. Guessing is always bad. We just showed you educated guessing is a strategy. Myth 3. Reading more books helps with MCQs. No. Integration and application help with MCQs. Books build knowledge. MCQ thinking is a separate skill. Myth 4. Toppers know everything. Absolutely not. Toppers know how to think about what they know. That's the real advantage. Thinking style matters more than content volume. Remember that. Here's what daily training looks like. 100 to 120 MCQs per day. Immediate review after every session. Not later, now. Maintain an error notebook and revise those errors every single week. And 1 to 2 grand tests per week. MCQs are trained, not solved. That's the framing. You're not doing MCQs to get them right today. You're training your brain to think in a specific pattern so that on exam day it happens automatically. And finally, and I mean this, do meditation. 10 minutes in the morning. 10 minutes when you think you are not going to make it. Not as a productivity hack. As a reset for the mind that is doing the hardest cognitive work of your life right now. Here's my last analogy for you. If you want to learn how to dance, will you learn it by only reading about the steps? No, you have to actually dance. Clumsily, badly, repeatedly. And then one day, your body just knows. Solving MCQs is exactly the same. You have to solve MCQs to learn how to solve MCQs. Not just read about the theory of MCQs. Not just watch this video. Solve them. Analyze them. Repeat. That is the only path to the rank you want. Good luck. You've got this.